Hi everybody, welcome back to week 7 of our course. This week is going to be a little bit shorter. We're going to continue discussing the concept of medicalization, and we're going to get into a few more examples of this concept and process. For a little bit of a refresher on the concepts of medicalization and pharmaceuticalization, I've got some definitions here. Medicalization, again, is the process by which conditions, processes, emotional states, or other just human experiences that are traditionally considered non-medical are redefined and then treated as medical issues. Pharmaceuticalization is kind of a spin-off of medicalization. This is the process of at higher and higher rates, recommending, prescribing, and using pharmaceutical interventions and medications to treat a variety of conditions that have been medicalized. So when it comes to the process of medicalization, it's really important that we look at the social and cultural context in which medical research is being conducted and medical knowledge is being generated. Medical knowledge is not generated in a vacuum. It is not purely objective. Objectivity in terms of studying humans, studying bodies and biology, we cannot be truly, completely 100% objective. There's always a social, cultural, and time period context that we need to consider when looking at this research. Of course, medical knowledge is vast. It's very, very important to the medical field and its function. It's very important to being able to treat medical conditions, but a lot of that knowledge is formed through research that at times can have sometimes questionable methodologies. Current research, a lot of the time, researchers are trying to get this really well-rounded, as close to objective as possible perspective on medical phenomena. But through a lot of history, medical research was being generated with a sample that looked a lot like the researchers. And so a lot of those researchers at the time, particularly in the 1800s and earlier, would be highly educated, so usually upper middle class, white men, a lot of the time non-disabled individuals as well. And so there was this lack of representation of people of other races, ethnicities, gender identities, and socioeconomic statuses and disabilities that kind of left a lot of people excluded from that medical knowledge. And what can happen, of course, in that case is that the medical knowledge being generated, that information or those standards being developed, won't necessarily apply to every single person. People are not one size fits all. We are not all the same, and so different social and cultural contexts are really, really important to acknowledge when generating medical research. A lot of research does a really, really great job of this today, but that is not always the case. It's important that we look at the stakeholders who are funding research to make sure that there is no conflict of interest in the results that are being produced. But these are things that we want to be thinking about when looking at the process of medicalization and medicine in general. So when we're looking at the social and cultural context in medicalization, or in the context of medicalization, we want to acknowledge how different things like cultural or social norms and beliefs, politics at the time, history and past experiences and events, how all of these different factors could influence the research that's being conducted, the knowledge that's being generated, and the possible diagnosis and treatment practices that are being used in our medical field. We also need to recognize that medicalization also includes the process of medical authorities becoming more and more powerful in the eye of the public. We have this idea that doctors are the end-all be-all expert on anything to do with health, and so what is being promoted and reinforced by medical authorities or by the medical field, this really reinforces our social norms. It solidifies our beliefs about health and illness and bodies, and this is something that we just absolutely cannot separate from objective medical knowledge. It's always going to be this blurred line between those social and cultural contexts, those beliefs, those norms, politics, history, biases, even things like isms, racism, sexism, classism, homophobia, queerphobia, all of these discriminatory beliefs and practices. All of this blends together into the eventual creation of medical knowledge and the implementation of treatments and diagnosis practices based off of that medical knowledge. Now that we've covered, again, some foundational information about what medicalization and pharmaceuticalization are, let's discuss a handful of examples of medicalization in practice, starting with sexuality and sexual orientation. So, sexuality and sexual orientation, throughout a lot of our history, particularly in the West and the United States, we have seen a pathologization and medicalization of queerness or LGBTQIA+ identities. What is pathologization, you might ask? This is a similar process to medicalization, where we are turning an experience or an identity or a human existence into a pathology, or we're reframing it to understand it as a pathology. This is not to say that it necessarily is. A pathology being a disease, an illness, a sickness, or a problem with the body or the mind or a person. So the pathologization, again, is the process of turning a human existence or experience into, or understanding it as, a pathology. A lot of our history, we have seen this happening to LGBTQIA+ individuals and their identities being seen as mentally ill, as potentially having some kind of biological, physiological, or psychological malady or disease. And the outcome of that misunderstanding, this interpretation, or this lens can be very, very negative and very discriminatory in a variety of different ways. We are not in class in person, so we can't discuss this as a group, but I would like you all to think about what are some things that you have heard about sexuality or sexual orientation that relates to the body or to biology. There are a lot of intersections of these ideas about, the brain, the physiology, the body, biology, and queerness. We do hear a lot of arguments about, say, transgender individuals being born, quote, in the wrong body, or having the brains of a person of a different gender, and a lot of different kinds of biological and medical arguments about sexuality, sexual orientation, and also gender identity. And sometimes these can be kind of tricky arguments because the research is very mixed on the potential biological side of sexuality or sexual orientation. So it's not something that's well understood. And a lot of the time what we do see is very similar to, Victorian era scientific racism. We could say scientific homophobia in this case, or transphobia or queerphobia, where this pathologization is relying on these arguments about the body and biology to make this point or make this case that there is something sick or diseased or wrong about queer or LGBTQIA+ individuals. Of course, throughout this class, it will become very clear that that is not the case, and any health discrepancies that we see amongst this population and people who are not a part of this community are due more to those things like homophobia, queerphobia, transphobia, and discrimination, rather than any implicit or inherent differences between the bodies of individuals in these different communities. So why did sexuality or sexual orientation become medicalized? How did that process look for this particular example? There has been a transition over several decades or even centuries here to lead to today's understanding of sexuality and sexual orientation, which luckily today we tend not to see it as medicalized quite so much as we did back in even just the 1980s and 1990s, 30, 40 years ago. But essentially, this started with a lot of sex research that was taking place during the Victorian era, the late 1800s into early 1900s, where for pretty much the first time in research history and sociological history, sexuality and sexual orientation were starting to be studied and defined and categorized. And so at this time, the so-called invention of homosexuality as well as heterosexuality took place. And what that means is the social construction of these categories and the creation of those labels. Those labels had not existed previously. Those labels were created or invented to describe human experiences and behaviors. And that was kind of a jumping off point for a lot of other research. Coming into the kind of mid-1900s, in the 1940s, Alfred Kinsey was taking part in a lot of sexuality research, again, for one of the very first times. There was not a lot of research in this area prior to some of these very groundbreaking researchers. So the Kinsey report came out in 1948. This was a report about a whole bunch of different survey qualitative research, a little bit of quantitative research that had been conducted across the United States and other regions on sexual behavior of individuals across a variety of different identities. And this was really kind of the first report of its kind. So as this is happening, people are getting more and more interested in studying sexuality and sexual orientation. More researchers are taking on these topics, and in some cases, people had an agenda just to understand these topics better, but some people had an agenda to essentially prove that there was a pathology or a disease related to these identities. This idea that being a queer individual or being particularly lesbian or gay, which were the categories or the identities most often focused on during this period, there was this idea that those were problematic, pathological, or potential mental illnesses at the time. This really came to a head coming into the 1950s during the Cold War and the Red Scare. If you're unfamiliar with this, the Red Scare was the West, and particularly the United States, having this dramatic reaction in this anti-communist perspective, or really just going after communism. There were a lot of people being questioned and blamed and just investigated for potential or presumed ties to communism. And during the time that this was happening, there was also something called the Lavender Scare taking place. And this is essentially the fear about communists and the fear about spies and Russian spies infiltrating the United States, and the CIA was working to try to combat these perceived dangers. And at the same time, there was this fear that because same-gender sexual encounters were illegal, marriages obviously were not legalized at that time either, and so the government and a lot of citizens believed, well, if queer people are okay with breaking these laws prohibiting same-gender relationships, and they are able to hide their sexualities from, say, their workplace, or if they're in the military, they're hiding it from the military. They could also be hiding other secrets. They could also be spies. They could also be, working for another state. They could be communists. They could be hiding all of these different things. And it sounds a little bit silly now at this point in time that anybody would think along those lines. But there were a lot of people who were questioned, whose lives and whose careers and whose relationships were dramatically impacted by this period in time and the Lavender Scare in the 1950s. And so this really was an example of this ramping up this belief that queerness was pathological, that queerness was bad or threatening or some kind of disease or state or status that a person has that is extremely dangerous and problematic. This really came to a head again in the HIV and AIDS epidemic during the 1980s in the United States. During this period in time, transgender women, people of color, and gay men were most intensely affected by HIV infections and deaths due to AIDS. If anyone's unfamiliar, HIV is the human immunodeficiency virus, and AIDS is a potential outcome of the viral infection with HIV that is acquired immune deficiency syndrome. And so those communities were directly and drastically disproportionately impacted by this pandemic, this epidemic. AIDS deaths were much higher amongst that community, and because of this medicalization and this demonization, essentially, of the queer community that had been taking place over the last century, really, at this point, research on HIV was really limited at the time. There was a lot of fear-mongering. There was very little assistance for people going through this epidemic, and that was largely due to who was being most disproportionately affected at the beginning of that outbreak. In case anyone has ever wondered why the L comes first in LGBTQ, that is because during this period in time, the stigmatization against gay men was so intense that a lot of medical practitioners would refuse to help HIV patients. And so lesbian women in the queer community at that time in the 1980s and 90s really stepped up to take care of those people in their community and make sure that they were safe, cared for, and comfortable, particularly in the end of their lives if they were individuals who were dying from AIDS. And so the community did decide to put the L first in the acronym because of that really altruistic sacrifice that took place within the community during that period in time. So there is a really dark, very difficult history with sexuality and sexual orientation in the West, in the US, and how we understand these concepts. Today, of course, we do not see them, or at least most of our society does not see queerness as a pathology or a medical issue at this point in time, but that has been a long process from the very start of this kind of research or discussion and discourse to today, and it is still, of course, not an issue that has been fully solved. Some of the modern issues that we are still seeing when it comes to medicalization of sexuality or the pathologization of these identities is compulsory heterosexuality, cisnormativity, and gender norms. So compulsory heterosexuality is essentially this societal pressure or the norm that every person is expected to be heterosexual or to be straight. This idea that you should be straight, or that if you are not, that there might be something wrong with you, or that that is problematic. We do see this belief or this perspective very widespread amongst our society, and this idea can be really closely tied to those medicalized ideas that homosexuality or non-heterosexuality or not being straight, this idea that not being straight is bad or sick or diseased or pathological. Of course, it is obvious why that could be very problematic for anybody who is not straight, for anyone who, feels that pressure to be heterosexual or to behave heterosexually, or, engage in behaviors or relationships that are socially acceptable, particularly in spaces where maybe people are very religious or more conservative. There can be a lot of pressure, and of course that can have very negative impacts on individuals who are struggling in those kinds of situations. And that's just interpersonally in general. That could be also in the workplace and in the medical field with medical experiences and doctor's visits. This is a really far-reaching kind of issue. Cisnormativity is very similar to compulsory heterosexuality. This is, again, the expectation or the norm that we expect individuals to be cisgender. There is pressure not to be transgender. There is pressure not to be non-binary or gender non-conforming. People in our society are expected to abide by gender norms, to dress the way that they're expected to behave the way that they're expected to based on the sex they were assigned at birth. It's implied that it is normal to be cisgender and to identify with that sex that you were assigned at birth, and by contrary, it would be abnormal not to. It would be seen as abnormal and potentially pathological or a medical issue to not be cisgender or to be trans, to be gender nonconforming or non-binary. And so these perspectives, compulsory heterosexuality and cisnormativity, these are really problematic biases, problematic expectations and norms, and they are very far-reaching within our society. They are associated with a lot of discrimination, a lot of bias, a lot of assumptions, harassment, and very negative experiences for members of the LGBTQIA community. And when these come up in medical contexts, of course, we're in sociology of health and illness, so that's what we're really focused on here. When those biases and that expectation that everyone is straight, that expectation that everybody is cisgender, when those biases pop up or when those expectations pop up and somebody does not meet those expectations, their experiences can be drastically lower quality in that health setting than somebody who is heterosexual or who is cisgender. And so we do see these very negative health outcomes or this poor medical care given to members of the queer community when these perspectives and these biases and these misconceptions are so very widespread in our society and in the medical field. Looking at a few very direct examples of the medicalization of sexuality and gender identity in this case as well, we can see that the Diagnostic and Statistical Manual of Mental Disorders, which is published by the APA, had until 1980, only 40 some odd years ago, a diagnosis of homosexuality listed as a mental disorder, particularly listed as a, quote, sociopathic personality disturbance. It's very obvious in this case why that sounds very much like a disease, very much like a pathology, and it was written in a book that psychologists and psychiatrists use to diagnose mental disorders and mental illnesses. It was removed, of course, in 1980, but we do still have other diagnoses in the DSM and similar publications that similarly can pathologize queer identities or gender nonconforming identities as well. Gender dysphoria was added in 2013 to the DSM. I have here the definition of gender dysphoria from the DSM. For the sake of time, I will let you read that on your own. But I think it's really important that we think about, should gender dysphoria be listed as a mental illness in the DSM? Should we be labeling the experience of gender dysphoria or the experience of a person's internal expression or feeling of their gender and their external expression of gender and their sex assigned at birth, if there is that incongruence there with those different aspects of identity, is that a disease? Is that a pathology or not? And what are the potential pros and cons of defining it as a disease or not? There are a lot of reasons why some people would say this is a good thing, that having this label or this potential diagnostic label or diagnosis is helpful or useful to especially the transgender community or gender nonconforming folks. But a lot of people would say, no, this is pathologizing, this is a problem for our community because this is implying that gender dysphoria or the existence or experience of being trans or gender nonconforming is a disease, a pathology, or something that is wrong with a person. So there are mixed perspectives on this topic. I think that there are valid arguments on both sides of that. I think that using the system of medicalization and the systems that we have in place in the medical field to access care and to access treatments that may be necessary for a lot of individuals during a gender transition, potentially having this label could be very useful. Insurance companies tend not to want to cover things if there is not some kind of diagnosis on the books, and so this can be very functional in that sense. But the pathologization of this experience of gender or this incongruence between a person's sense of their own gender and the sex assigned at birth, that pathologization can also be very problematic for a lot of reasons. So think about that, and you don't have to come to a conclusion right now. There isn't exactly a right answer, but it's definitely something that we as sociologists should be considering and potentially pushing for change if we feel that that is something necessary or beneficial to the community when it comes to these kinds of diagnostic labels. Switching gears now to talk about another example of medicalization, let's talk about the medicalization of childbirth. The key point of this portion of the lecture is that pregnancy is not a disease, even though it is often seen as a medical condition or even a disability by the standards of the Americans with Disabilities Act or the ADA. Also, another key point is that childbirth itself is not pathological. Childbirth is a normal part of the human experience. It is not something that, again, is a disease, a pathology, or something that is wrong with the body. It is possibly the most normal human, non-medical potential issue or experience that we could really have. So with this in mind, let's think about, why are pregnancy and childbirth seen as medical issues? What is the purpose of understanding these experiences as potentially diseases or pathologies or a state of being that when a person is going through these experiences, they need to be going to regular doctor's appointments and they need to be regularly in the hospital, particularly for childbirth? Um, why do we have this belief, especially in the United States, that every single birth needs to take place in a hospital, that that is the best way or the only way that that should take place? It's interesting to think about, how did we get here? How did we get to the point where we see these things in this way? And should we see them differently? Or is this the most accurate or the most beneficial kind of perspective? Another important thing that we'll address when talking about the medicalization of childbirth is that in a lot of medical contexts, we see an overuse of risky or unnecessary interventions, particularly with childbirth. We see a lot of C-sections that are not necessary. We see a lot of other interventions that can be harmful to the parent as well as the baby in these kinds of contexts. And so this medicalization can potentially lead to that overuse or that use of risky and unnecessary interventions. And we really need to question, is that a good thing? Why is that happening? What is leading to the use of these interventions like C-sections? And do we have alternatives? All very good things to be considering. So when talking about C-sections or cesarean sections, for anyone who is unfamiliar with this, I have a little graphic here on the slide of kind of a very simplified version of how this type of surgical procedure takes place during childbirth. This is essentially the removal of the baby through the front of the body of the person giving birth rather than a vaginal birth. C-sections are increasing in prevalence across the West, especially the United States. They are very, very common. I'm sure we all know people who have had C-sections. And the unfortunate thing about this intervention is that there are a lot of risks. A person can have severe blood loss during a C-section. There's the potential for infection with any kind of surgical site. There can be anesthesia complications because a person is anesthetized during this procedure, of course. This can also be a very traumatic experience, just like a lot of childbirth experiences. But for a lot of individuals, they are conscious, not fully unconscious, anesthetized during a C-section, and that can be very difficult for a lot of reasons. It can also be difficult for loved ones who are in the room to witness a C-section. And then, of course, with any kind of surgical incision, there is also the risk of potential nerve damage, which can lead to long-term or even lifelong problems for that individual. So, why are C-sections becoming more common? If they have all of these potential risks, why are they happening so often? There are a lot of different reasons why this might be the case. A few of the reasons discussed in our readings this week are related to the kind of McDonaldization or rationalization of the medical field, and particularly childbirth. So this idea that efficiency and productivity are so important. We need to get people in, get people out, and we need to make profits in our hospitals. And so a C-section is a lot faster than a vaginal delivery. And so in this case, a lot of the time, a C-section might be done simply to save time. But also the fact that since this is a surgery, there are heightened costs associated with a C-section compared to other types of delivery. And so a hospital can make more profits from doing C-sections, and they can do more C-sections than other deliveries in a faster amount of time. So that's more profits in a shorter amount of time. It's not to say that hospitals are only doing C-sections to make money. There are, of course, reasons why a C-section can be very necessary. Some people even opt to have a C-section rather than a different kind of birth because that is their own personal choice and that is what feels best for them and their situation. So there are a lot of reasons why C-sections are taking place, but we do need to be critical of when they're becoming more common in a way that implies or suggests through the data that it is a profit-focused or efficiency-focused intervention. We need to be critical of that, of course. We also need to be critical of when C-sections are taking place because other interventions were unsuccessful
problematic or risky, leading up to a C-section becoming necessary. So the use of the supine position for birthing is very common in the United States. A lot of people give birth on their back, and that is actually not the most effective way to do so. Of course, gravity is not helping in that kind of scenario, and that can actually cause a lot of distress for the baby and the parent. And so in that context, of course, epidurals might be needed to reduce the pain in that situation. There might be more tearing, there might be more effort or more muscle strain, more trauma, usually a longer birth time or a longer labor time. And all of those issues can lead to a C-section also becoming necessary for the health and safety of everyone involved. So, in general, when we're talking about the medicalization of childbirth, we want to think about why have these human experiences been medicalized? What is the outcome of this? Prior to our modern medical institutions, pregnancy and childbirth were something that were not necessarily considered to be medical. A lot of the time, pregnant individuals would not go for a whole bunch of doctor's appointments. That was maybe not very accessible in previous centuries, and that's not to say this was a good thing, but we have this process over the last couple centuries, and especially the last handful of decades, where hospital births and regular pregnancy checkups have become the norm rather than something that only the wealthy might do. This is something that pretty much everyone is expected to do and that a lot of people do take part in. And so, what are the outcomes of understanding pregnancy and childbirth as medical emergencies or medical states? What happens when we understand these things in that way? What happens for the medical institution? What happens for medical practitioners? What happens for the individuals who are getting this kind of obstetrics care in these contexts? There's a lot of different outcomes of this process. It's not to say that medicalization is a bad thing in this case, but we should be critical of any potential negative outcomes of that process, especially for patient outcomes. So I discussed this a little bit before, but the language of medicalization is something that can be very useful for a lot of different reasons. A lot of the time, the queer community, especially the transgender community, takes advantage of that language of medicalization and that diagnosis of gender dysphoria and uses that to get insurance companies to pay for treatments that a person might need or want. So in that case, that could be a positive thing that we have this language of medicalization. But we really need to think in this context, what really makes something a medical status? Once something is medicalized, what are we really focused on in the healthcare sector? What are insurance companies focused on? And what is the general public thinking about when we consider these issues? Is a medical status something that's about the physical body? Is it about physiology and biology? Is it about a person's mind or psychology or cognition? Perhaps the person's capabilities, things that they're able to do or things that they're not able to do, or maybe their experiences of life and the world. Maybe it's all of these things, maybe it's a mix of some of these things. I would say that depending on the medical status or the diagnosis, depending on the condition or the experience that's being medicalized, we might be looking at different facets of all of these different categories. And so, in medicalizing something, in turning something into a medical status, how are we defining that? And then how does that language become useful or potentially harmful for the community that lives with that medicalized experience or condition? For those who do live with a medicalized condition or medicalized experience, there is something called medical rights seeking that people might engage in. And so medical rights seeking is essentially looking for, insurance coverage or the legal and formal recognition of a condition as medical. Some pros of this process or this experience of medical rights seeking: a person might be able to get more benefits, potentially disability benefits, insurance coverage, and in some cases, they may not be blamed for their condition or their experiences. Particularly for individuals who are disabled, this lessening or removal of blame, especially for individuals who are, say, not able to work, when something becomes medicalized, now we're seeing it as a genuine, real, bona fide disability or medical problem. And so if that person has this labeled so-called pathology or so-called medical problem, now it's not really personal choice. It's not anything about their identity so much as it is a just real labeled, validated medical experience in the eyes of the law, the medical field, and perhaps the public. Some cons, of course, of medical rights seeking and using this language of medicalization or embracing those medicalized labels. This can reinforce medical authority and say implicitly or explicitly that institutions like the American Medical Association or the APA, the American Psychiatric Association, that they are the end-all be-all authorities on these experiences, labels, and categories. And of course, we know that sometimes that research is not perfectly objective. That research may not be perfectly representative of everyone who has those experiences. And so sometimes medical knowledge and research and understandings and a lot of publications or policies that come out of those practices, sometimes they are not beneficial towards everyone in a group. Right? If a research study or a publication overlooked an entire racial group or an entire group, say, of gender nonconforming individuals, looking only at cisgender individuals in research or in a clinical trial, we might have research that is not fully representative and therefore not fully useful to the entirety of our population. And so when we lean into this language of medicalization and we embrace these labels, we are essentially reinforcing that medical authority and saying this is our objective reality. That's not to say this is always a bad thing, but we do need to be critical of medical authority in the sense that we need to make sure that representative research is being done, that there is not a conflict of interest in medical research taking place, and that that medical authority is really doing the utmost to make sure that that is high quality knowledge and high quality policy coming out of that knowledge. This can also, of course, perpetuate othering, the language of medicalization, and creating these labels for these diseases, mental illnesses, or pathologies that can perpetuate this idea that somebody is sick or different or that they have a problem with their body or with their mind. And because of ableism, because of this widespread belief or practice of discriminating against disabled people or people with chronic illnesses or diagnostic labels of all kinds, this can lead to, of course, discrimination for individuals who use this language of medicalization to describe themselves or who do lean into those medicalized labels. Getting into a little bit more of a specific example of medical rights seeking, let's look a little bit at the LGBTQIA+ individuals seeking sometimes what we would call remedicalization in the case of HIV and gender-affirming care. Remedicalization is essentially the reframing of a previously medicalized issue or experience as a medicalized issue again. So queerness was pathologized and seen as a medical issue and then kind of reframed as no longer a medical issue in certain contexts. And now we are at a point where some groups and activists and individuals are seeking this remedicalization where we again understand different queer identities not as pathologies but as medical statuses. And so particularly for transgender or gender nonconforming individuals who are seeking gender affirming care, so hormone therapies or surgeries, potentially voice training or physical therapy. There are a lot of different kinds of gender affirming care out there. For individuals who are in that situation, it can be beneficial again to have those diagnostic labels, to do this medical rights seeking by using that language of medicalization to get insurance companies to pay for this treatment. Again, insurance companies will not usually pay for something if there isn't a diagnosis on the books. And so that remedicalization process of, again, understanding particularly trans identities as being potential medical statuses, or that trans individuals have a medical status that facilitates or necessitates medical interventions and treatments that can be potentially beneficial to this community, that use of medicalized language. We also see, of course, amongst the queer community and in general, HIV prevention drugs being something that is highly medicalized. Of course, having HIV or an HIV infection is a medical status. There are medical concerns associated with an HIV infection, but particularly for transgender women and gay men, being able to access HIV prevention drugs to decrease the risk of becoming infected with HIV, that can go hand in hand with this medicalization of sexual orientation. And so there's this understanding that people in those communities may be at higher risk of HIV infection or getting an HIV infection. And so people can self-disclose and say, I am a part of this community. This community is medicalized in this way where we have this association between HIV and queer identities, especially for gay men. And so I want to access these HIV prevention drugs. I want my insurance to cover these drugs. And what we might see on a patient's chart is something like, quote, high risk sexual behavior or something like that. Of course, that can be stigmatizing, but using that language again to access these treatments, to seek these medical rights, can be beneficial to patients even when that stigma is still there as well. Looking now at another example of medical rights seeking, let's discuss our unhoused, impoverished, and unemployed populations in the United States. A lot of the time, people who are going through these experiences may be seen as having a particular medical status that maybe necessitates unique benefits that somebody who's not going through homelessness, poverty, or unemployment, maybe that person would not be eligible for these same kinds of benefits. Just like we discussed a moment ago, how do we really define a medical status or a medical condition? Are, being unhoused, being impoverished, or being unemployed medical conditions? And why or why not? There are some laws in certain states in the United States that do define essentially these experiences as medical experiences or medical statuses, that being unhoused is potentially related to a lot of different medical conditions and a lot of potential outcomes of a person's medical status. And so because of socioeconomic reasons, because of class-related reasons and access to resources, privilege and oppression, individuals who are going through these experiences can seek medical rights in a way that is not exactly directly tied to their medical experiences outside of their socioeconomic experiences. There is nothing about a person's body that changes necessarily biologically or physiologically because they are experiencing homelessness, poverty, or unemployment, but we do know that the health outcomes of those experiences, especially over time and over longer periods of time, we will see a decline in health and poorer health amongst these populations, but those individuals are not inherently, born with any kind of health status or condition that dooms them to a negative health experience or poor health in the future. It is the experience of these socioeconomic positions that can lead to negative health outcomes. So, on a legislative side, should we be considering these experiences or these identities or statuses to be medical conditions? Should you be able to get insurance benefits or government benefits because you have any of these statuses, because you are unhoused, impoverished, or unemployed? And why or why not? What are the benefits and pros and cons of implementing that kind of medicalized understanding of these different identities? Another final example here of medical rights seeking and taking advantage of the language of medicalization is the example of addiction. Addiction, a lot of the time, is considered to be a medical condition or is framed as a disease in a lot of different contexts. Some people would push back against that perspective and say that addiction is a choice, or that addiction is something that a person, that their individual choices lead them towards. Of course, in a sociology class, we know that social and cultural factors, socioeconomic factors, experiences of homelessness, oppression, discrimination, loss of a job due to disability. There are so many different factors that could lead a person to develop an addiction, to take part in drug use or drug abuse. It's always a little bit more complicated than just individual choice. But it's worth considering, why might we consider addiction to be a medical condition or a disease, or what arguments are there that say addiction is not a medical condition or disease? An addiction will never develop spontaneously without partaking in drug use. And so there is an element of choice or individual behavior, at least, outside influences aside, that does lead to the experience of addiction. But is that a reason to not consider addiction a medical condition? Perhaps. But we also see other factors with people's health, like heart disease, that we could see in some contexts, heart disease and the development of heart disease may be also related to individual behavioral factors and potential choices. Of course, also affected by sociocultural factors. We don't make choices in a vacuum. But we need to consider why might we think that addiction is or is not a medical condition, or that addiction is or is not a disease. And depending on how we understand it, especially in legal terms or in the medical field, what are the potential outcomes of these different understandings? We have covered a lot about medicalization and pharmaceuticalization for these past 2 weeks. There is a lot more we could also cover about these topics. There are countless examples of the potential pros and cons of both of these processes. We talked a lot about some of the negative outcomes of these processes. We, of course, see the pathologization of intersex people, fat phobia, pathologizing queer identities and people. We see unnecessary and risky health interventions and, of course, traumatizing medical experiences that could, in a lot of cases, likely be avoided, all as potential outcomes of medicalization in different contexts. We also have seen examples of how a lot of different groups, and particularly activists and marginalized communities, use that language of medicalization to their advantage. And they kind of turn the system on itself and say, all right, I'm going to take these labels and I'm going to gain new rights and new protections. And I'm going to do this medical rights seeking and get my insurance to cover these treatments, or get access to these medications, or be absolved of blame for my condition because I have this label now that says that I have a real disease. A lot of groups are using that language to their advantage, and that's a very, very interesting turn of events. This is a huge topic. Medicalization is really at the core of the sociology of health and illness, or social medicine in general. There's so much we could cover here. There's a lot of nuance to these topics. So that was just a very quick kind of crash course overview of the surface of some of those topics. We really can't get into all of the nitty-gritty details, but I would love to discuss this in more detail with anyone who's interested. Feel free to reach out if you want to learn more, if you want to talk about any of these topics. We could really go down this rabbit hole for days and days and days. So thank you for being here for the last 2 weeks of this topic, and I will see you next week.